inspected by the state officials and see that they are used for the purposes that they are there for, which is to continuously, on an incremental basis, improve service delivery. And but also secondary to that, because they recently now, as said by the DG NHIA, they are rounding up work on the guidelines based on which the NHIA Act to be implemented. I think we cannot no longer run away from the fact that we must significantly invest in primary health care, because for services to be purchased from the place where a vast majority of Nigerians will access it, it needs to be at standards that are acceptable all across Nigeria, not just standards that are acceptable at the local level. And so was the basis of the health summit held last year, and acceptance of the ministerial agenda of primary care transformation, and work has started on that, but there's need for very strong advocacy at all levels for new investments and continuous investments to be made to be sure that at every point in time, the primary healthcare centers are positioned as primary providers to provide quality services to Nigeria. Central to this is really around the issues of human resource, the practical environment where these services will be delivered, particularly as it has to do with providing accommodations, power supply, and potable water for midwives to be able to provide quality services. And also, as particularly at this time, as we get on board new chief executives at the state level, I think the Nigerian Health Watch is uniquely positioned to target advocacy towards them on the need to invest in the primary healthcare centers as a prerequisite to position their states to rapidly absorb and benefit from the implementation of the National Health Act. Thank you.
Thank you. Thank you so much. The points about Nigeria Health Watch targeting advocacy to the new CEOs, duly noted. I heard what you said about the three key enablers. Oversight was set up, enhanced understanding of healthcare workers, resource management at the primary healthcare level as well. And what you said about barriers, accountability still is an issue in the health sector. Every time we have a convening like this, or we have a dialogue like this, and the Budget Office of the Federation gets to come, they tend to harp on accountability, but also on utilization of the funds that are already allocated to the health sector. So those were very, very solid points, sir. Thank you so much for sharing your thoughts. Okay, so I'll come back to Dr. Jadesola. So every stakeholder mentioned in the NHIA Act has a critical role to play to ensure that it is successfully implemented. What learnings do you think can be garnered from the implementation of the NHIS Act of 1999 that you think would be key to implementing the new act?
All right, thank you once again for the question. So basically, the NHIA Act of 2022 is making healthcare or health insurance available to all Nigerians, all residents. And basically what that means is that we're expanding the universal health coverage for all. Now, this will have to be driven by all the stakeholders. What we've had in the past is just some top-level, top-up approach. But I'm so glad to see the market women and the drivers and everyone involved in the healthcare delivery. So the hospitals, the HMOs, the TPAs, third-party administrators, of course, the Federal Ministry of Health, the NHIA, the DG, and all the collaborators, all the stakeholders must be involved and everyone must come in. So now the act has been passed, but like we know in Nigeria, so many laws have been passed. It's the enforcement and getting this act to be implemented is the next stage, and I'm glad we have the legal people drafting the bills and everything. Beyond that, how do we implement it? The implementation is so critical, and that means all the stakeholders must be involved. And I must just mention here that there's really no use reinventing the wheel. I've been part of a delegation that started a community-based insurance program. We call that the Shonga model that was done in Kwara State in 2007, where we had the DG of the World Health Organization then, Margaret Chan, and then was in Shonga, Kwara State, and the Kwara State government actually adopted this model, which is still running. All the 3 senatorial districts were involved. The subsequent governors took it up. And basically, it covered the entire state. So we can look at it. We had the BOT, the Emir of Shonga then, who is also a doctor, was also involved. And basically, everyone took it up. They took ownership. So that even when the funders, this was funded by the Health Insurance Fund of the Government of Netherlands and then the World Bank. When the funding drifted and we had the government to take over the funding, it was seamless and everything gradually, evolved when the funders left. So basically, implementing the act is the next stage and getting everyone involved. I also want to remind us that Nigeria is a signatory to the Abuja Declaration of Health. And I'm glad the DG also mentioned it. Now, it's a constitutional issue, but it must be addressed. If we sign that we will give 15% of our budget to health systems, then we have to implement that. But what do we see in Nigeria today? Less than 4% is going to health. Less than 4% of the budget. And of course, he has just told us it's not even in the concurrent list. It's not even there. It's in a residual list. The federal government is not taking ownership. The state governments are also not really there. So how do we change this? Then it's a constitutional issue. I also must mention we also have a pact with the Lagos State government also in the past with the Market Women Association. Then, I mean, incidentally, it was the president-elect's mother, we call her Yamogaji, that took ownership. The market women have a very strong association, just like the drivers association. Those are informal sector people that must be covered. Less than 5 million Nigerians are covered, but getting to these informal associations, market women, and drivers, different people. We had this Kablan project. So basically, this has been done in the past. Now, can we revolve it? Can we learn lessons learned from this project and also make it work, starting from the grassroots, the bottom-up approach? The other thing is also working with telcos. What do we see as HMOs? We find people that cannot pay the whole premium upfront. So we now need to partner with banks, and we're actually doing that in Agza Mansard, where we have contributory schemes where people may not be able to pay the whole annual premium. But with banks and with telcos, telecommunication companies, they can pay instrumentally, and these are deducted from them gradually so that it doesn't push them into this multi-dimensional poverty that we're also talking about in Nigeria. So if they can't pay the whole premium of even as low as 60,000, then we can do a 10,000, 20,000 deduction. So there's a collaboration that must also be made between the banks, the telecoms, to also help drive this universal health coverage. Lastly, collaboration with the providers. You know, before I went, I'm a consultant physician. Before I came back to the HMO practice. I started with HMO, I went into clinical practice, and I'm back to HMO. But basically, what am I saying is, each time I went to my hospital then in Victoria Island, the doctor, my patient said, "Doctor, when are you leaving Nigeria?" The brain drain is real, and the earlier we address it, the better. All our doctors are still the ones in US and UK. Now, the bottom line is until we fix the health system and make it look like what they're going for in UK and France and US, then the doctors are leaving. The nurses, everyone, not just the doctors, what do you call them, lab scientists, everybody's leaving. So basically, we must fix the health system. We must collaborate with the hospitals and fund it, starting with the state hospitals, the general hospitals, and of course, supporting the private hospitals also to deliver quality healthcare. We must collaborate with hospitals and other business-to-business partners, the TPAs and other people to access this, to be able to disseminate this universal health coverage across different groups. I mean, we talk about the vulnerable groups and the other people in Nigeria, informal sector, the prisoners. I mean, there's a T-ship to tertiary institutions, students Absolutely. In the tertiary institution, basically reaching everybody in the informal sector. I mean, and the informal sector is 95%, just we have about 5% of people in the formal sector. Yeah. So until we address this informal sector and reach out to them, then we can win on these gains. And I just want to say it's possible, it's a welcome idea, and I'm particularly glad because I have seen people die of malaria that is totally preventable. Preventable diseases, like the DG said at the beginning, we have a double jeopardy of both communicable and non-communicable diseases. So we're now having a lot of chronic diseases, hypertension, diabetes, because of our changing lifestyle. And at the same time, our children are still dying of malaria, measles. Yeah. And we must fix the system by funding and collaborating with all stakeholders. Everybody is important, the market women, the doctors, the hospitals, the nurses, the telcos, telecommunications, banking industry, everybody coming together to make access available to all.
Thank you so much. Thank you so much, Dr. Jadisola. I hear you clearly. Stakeholder involvement, stakeholder engagement is important. We need to leverage past successes. There are some schemes that have worked in the past. What can we learn as we try to operationalize the NHIA Act? We also need to implement the 15% Abuja Declaration. We need to partner with telecoms, with banks. We need innovative financing mechanism. The next panel is going to really dwell on that. And you talked about the missing middle, which the first panel just spoke on, and we need to target the missing middle effectively. All right, so I'll come to you, Dr. Jonathan. Could you share some of the factors that led to the inability of the NHIS to effectively expand coverage of health insurance? And how does this new act strengthen the NHIA's ability to achieve this mandate?
Thank you very much. I think the reasons that made it impossible for us to go beyond maybe the percentage we are just about 8.5% of the population now. In fact, a lot of the speakers previous speakers mentioned that. First, and that's why I said when we get to a certain level, look about the context issues that led to the new law. First, the DG Budget Office talked about the political structure of Nigeria and looked at the constitution where health is nowhere. You know, we used to hear people tell you that health was on the concurrent legislative list. It's never. When you tell them no, it's nowhere. So like that, it was very difficult for the then NHIS to get even the states to come in. Given that the previous law, the repealed law, was formal sector centered. So if we couldn't get the states, even the organized private sector, because of the voluntary nature, it was very difficult to come in. For the informal sector, the law didn't say much. It's only in one section, the old law, I think section 48, it talked about coverage of self-employed, and that was it, without making any provision for subsidy financing for the poor and vulnerable. So NHIS then was working in an uphill task. It was difficult. Even if you look at the category of persons, the groups, like the formal sector of the Federal Civil Service, I'll tell you they're almost 100%, but people don't know. You understand? Mm-hmm. If you, with the states, 2 states came in, Bauchi and Cross River. I don't know, I don't think they lasted up to how many months, and they went off again. And that was what led NHIS to begin, even minus the law, the decentralization policy that NHI drove. First was the realization of this. We cannot sit down here and attain universal health. We need to carry the states, knowing fully well that constitutionally issues that relate to health lie with the states. But we need to come and coordinate them. Otherwise, we'll continue fragmenting the system. So that was why we now brought them. And now, if you look at the law, a lot of these issues that I've mentioned are taken care of. Even the poverty, my DG talked about it. In 2019, the Lancet report talked about 40.1% of the population having been multidimensional poverty. If you look at the report, NBS report of ending of last year, 2020, is 63%, which is almost 133 million persons. So when you have this level, so even ability or willingness, even ability to pay is hampered. Though I know that in the UHC system, ability to pay is not even what we used to. Rather, we talk about needs, the real needs of the people to take care of them. So these are some of the problems. So let me begin to take them. One, the problem of the political context. If you look at when my colleague was talking, he told you about the state health insurance has been mainstreamed into the law. That's one. So we've got that. When we're talking about the issue of equity problems, the problems of taking care of the vulnerable, poor, and needy. There was nothing in the previous law. We have brought in the vulnerable groups fund in. So the problem now, or the challenge now, is how to get the political leaders to be committed to funding that equity fund, knowing that it's their social responsibility to give Nigerians good health and universal health care, which they signed. So when you look at that, we equally come to, and that addresses the issue of even the socioeconomic context that led to the law. The issue of non-mandatoriness of the previous law, because it was voluntary, we've taken care of it. She equally mentioned that it's become a mandatory law for everybody in the country, and we're working to see how we can enforce that mandatoriness within the system. I think, because there are a lot of other issues, even some operational reasons, which have been taken care of. All these are part of the things that made it impossible for the NHIS then to be able to go beyond where we are now. So let me thank you very much. Yeah.
Thank you so much for sharing your thoughts. So very quickly, before we take questions from the audience, I'd like to ask Dr. Ogwe one last question. And it's, how can we put measures in place to ensure uptake of health insurance at the primary healthcare centers?
I think this meeting in itself has answered that question. It's the NHIA. I did crack a joke with the DGs at one of our meetings that you'll be shocked that at the NPCD we are far more excited about the NHIA than they are in the NHIA, because that's what actually addresses the challenges at primary care. If you can provide financial access to care, it will solve a lot of problems. So we need the Vulnerable Care Fund to use the primary healthcare centers as primary providers, because if we receive the capitation, we begin to create a funding as we continue to improve accountability that becomes sustainability, that automatically creates sustainability for primary healthcare in Nigeria. We're modeled to find out that if we get at least 40% of target populations, if we take on at least one primary healthcare per ward, which is the focus of federal government now as it comes to primary healthcare, to have one level 2 fully functional operational primary healthcare center in every political ward, targeting at least 8,800 across the country. That, and we can capture and assign to them MREs that make up just about 40% of the population. They can generate enough income to actually sustain themselves almost indefinitely after the initial investments have really been made to see that they have the right infrastructure, personnel, and equipment to work with. So that's really the answer. Implementation of the NHIA, putting in place the Vulnerable Group Fund, and investing in primary healthcare to get them to be at a position where the NHI is very comfortable to continuously purchase services from them. Thank
Absolutely. And earlier you had spoken about what needs to happen in primary healthcare centers. You need human resources for health,
Exactly.
You need equipment, you need infrastructure, you need potable water, so that people, I was on a radio show yesterday and someone had sent in a comment saying, how do you make sure that you get the same quality of services from health insurance as you would if you were paying out of pocket? And that's an issue that everyone talks about. When you talk about health insurance, like when I pay for health insurance and I go to access care, I get substandard medication, or I get treated less important than those who are paying out of pocket. So those are definitely issues to look into. Does anyone have questions? I'm going to take the first two hands I see. Great, I've seen Dr. Hope and that person, and that's it. Thank you. I'm sorry, but we're out of time. I can't take a lot of questions. So I'll take Dr. Hope's question first.
Not a question, just to add a comment. The issue I wanted to raise is because of, during these deliberations, there was this question of how do we want to move forward in terms of financing primary health care. And most times we always forget that before all these so-called specialists and general hospitals, Nigeria was mainly being serviced by primary health centers. That's number one. Number two, during the last COVID pandemic, the National Primary Health Care actually deployed the primary health centers to provide immunization for us for COVID, and it did work excellently. So we should ask ourselves, under this program being implemented by the NHIA, what is stopping NHIA and National Primary Health Care from agreeing that there should be a common primary health care level that will be funded by NHIA across? So primary health centers should not be for only vulnerable group people. That is discriminatory. Inequity is being displayed. As a matter of fact, every primary health center, like what this survey has shown, up to 60% or thereabout actually use public facilities. It is always the private sector being driven by certain interests that always come to tell us it is the private sector that should drive that level of care. And yet the cost structures cannot be the same. So why don't we aim at saying primary health centers should be the first basis of care, irrespective of the service you want to go. So if you go to a primary health center, if the service you need exceeds that package, you can now move to the second level of care, in this case, a secondary. But why go, for example, to a very specialist hospital to go and receive primary care?
Yeah.
It brings out poor strategic purchasing. Unfortunately, I'm not talking on that now, but I just want to raise it. that it is very mandatory that public funds being channeled through NHIA go to the primary health centers, not just for the vulnerable group, but for both the vulnerable group and those being routed through the formal sector.
Absolutely.
Thanks.
Thank you so much, sir. And I'm looking forward to your presentation later on strategic purchasing.
All right, thank you very much. Talking about roles and responsibility, I just want to say that there's a limit the NHIA can go in terms of covering all the necessary aspects of implementing this. And so what it means is that as players in the health sector, we need to look at where we can add value to the work that the NHIA is doing. My name is Kenneth Okoineme. I work for Society for Family Health. I just want to say that in this journey, we're also trying to support that process. So Dr. Agada is here. We've tried to support, trying to put together the benefit package for HIV/AIDS, TB. So just as NHW is doing now, let's look at areas that we can add value to the implementation of the NHIA Act and see that we make progress. And the second thing I want to talk about is issues around primary health care. Of course, we know that one of the biggest challenges for primary health care is that people don't trust the services there. So we need to be innovative around dealing with those challenges. And what am I saying? SFH is part of the Data Contributing Health Scheme, access to finance engagement. And so what is it doing? It is bringing in private sector players under a PPP arrangement to take on primary healthcare centers and operate them and see what changes can happen. So under that kind of arrangement, there are certain standards that are brought to the table. And at the same time, you create a mechanism for accountability around how those primary healthcare centers are being run. And one of the things that we have noticed is that while providing all of these services, at certain points, when elements of service provision drop, let's say, for example, drugs stock out, drugs run out, you find that demand generation drops.
Right.
And so you need to deal with all of those issues, and we have to be innovative about it. And that's one of the things we're also asking that the NPHCDA look at. What are the innovative approaches that we can use to deal with this? So that even the application of the Basic Healthcare Provision Fund can use some of those streams to say, how do we move the primary healthcare centers from this level to this level? And while we are doing all of this, we should think sustainability in mind. And so for me, these are some of my contributions. Thank you very much.
Thank you for sharing your thoughts, Kenneth. It was good to hear about the Access to Finance program happening in Delta states. So there's one last question I'll take before I hand over the mic. There's a question from participants online, and they're saying, how soon are we looking at to achieve mandatory health insurance towards universal health coverage? Any targets, any steps at transparent monitoring? Dr. Jonathan, do you want to take that question?
Thank you. In fact, our target is to attain universal health coverage by 2030, like stated. So, but it's a journey, which by the time the guidelines, all the documents that will guide the implementations come out, I think that will tell us exactly when we hope to get there. And not just the document. The other issue is the issue of funding. If we can I am an incurable optimist that if we can achieve universal coverage in 5 years, given the right things. One, if the government can listen to let me tell you one thing. Even when the DG of a budget office he was talking about the telecoms tax. But I tell you that it's not in the law.
Yeah, it was taken out.
Because, no, it was in the law.
No,
it was in the law.
Yeah.
That's exactly. It was taken out. In fact, the law was with Mr. President when they said, okay, people make comment. I know that we know the people that come out, we know where that thing was taken out. For what reason? For no reason. And it's not even as if you're asking government to pay tax. This is Nigerians contributing. It's not you're asking government to bring that money. If I make my call, I pay. I'm paying, not that government. You understand? It's not as if you are. Because the essence of one of the objectives of NHI is to reduce the excessive dependence on government. Government that is already flat. All right? You can hear there's no money anywhere. So, but our health system must function. So that's why we are looking for how do we are talking about innovative financing, both at the level of revenue generation and strategic purchasing to get things gone. But we must move forward. Whether government does not have one. Now they are telling us that our debt to GDP is almost, in fact, servicing our debt is almost 100%. In fact, we know that we're even entering a more trying time, but we just pray to God to give us.
Thank you. Thank you so much, Dr. Jonathan. We're out of time, so I'll just take 30 seconds, your final thoughts, please. I'll start with Dr. Ogwe, actually.
Thank you. Thank you so much for the opportunity. I think the thoughts have been further echoed by participants right here in the hall. I'll just say thank you to Dr. Hope and the Society for Family Health representative that, yes, this is actually what we are doing. The MPACDA has been working with the corporate private sector through PISHN to see how better they can scale up at scale, see how they can contribute to improving primary health care. But the idea is that in working that part, you have to maintain the role of government, which is that to ensure that there's equity and availability of service as the least cost to people. So the idea is that government focuses on getting one PAC per ward that is there at standard, providing services, and the private sector continues to help us through PPP arrangements to scale up to other primary health care so that at every point people always have a fallback choice that they know that government, who is the primary responsible person to provide health for its citizens, is working. And the call for the NHIA to use primary care centers as primary providers have echoed that, and that really is the key to it all. Once that happens, then you begin to see quickly improvements in access and in demand for services. With the BSCPF and others, most things around logistics are being fixed, but this is all encapsulated in the primary health care reimagined agenda that we continue to advocate for more investment to make it happen. Thank you so much.
Thank you so much, Dr. Ogwe. Dr. Jadisola?
Yes.
30 seconds, please. 30 seconds.
All right, so I want to thank the organizers of this program and conference. It's really, really a good one and so needful at this time. I also want us to be positive, to look forward to a universal health coverage for Nigeria. If you are a citizen, you should be concerned about all the needless preventable deaths that we see every day. Not even talk of non-communicable diseases, cancer, colonic cancer, and other cancers that are rising all over. So basically, it is possible, it's achievable, but we all need to do our part as stakeholders and as HMO representative and other stakeholders, especially the NHIA. I also want to encourage them to do the enforcement and implementation of this act and focus more on regulating the system and less on all the other parts they're doing, because if they can really implement this and get this mandatory health insurance, get all the employers of labor employ more than 5 people to put them on health insurance, then we're going to reduce the poverty, out-of-pocket payment that is driving people into this multidimensional poverty. We're going to also improve the workforce, because when people are healthy, then they can be more productive. And of course, we're going to retain our workforce by building the primary health care. Doctors are nurses, everybody's living every day, but we can reverse that trend by retaining doctors and other healthcare workers in the system, by improving the system, funding, innovative funding. We must fund the system. There's no magic. What they're giving in UK is still the same Nigerian doctors, but they have the equipment, they have the diagnostics, and we can get the same here. It is possible. Let's do our part.
Thank you. Thank you so much, Dr. Jais. I hear you about the Japa syndrome. It's real. Dr. Jonathan, 30 seconds. Final thoughts, please.
Thank you very much. I think the only thing I have to say is that one, we started the engine to UHC using insurance, health insurance, when this new law was signed. That is one. And we're at the level of implementation, and what I only ask everybody here is that the NHIA cannot do it all. So we need all the support of everyone, because what the mandate we are pursuing, universal health coverage, is a developmental goal for the country, not for NHIA, but we are just trying to do it. So we need the support of everybody. We need to collaborate with as many people as possible so that people will come in and not come in because of my interest. But what can we give to the system? That's just what
Thank you so much. That's all the time we have. Thank you, everyone. You've been an excellent audience. Thank you for sharing your thoughts. Please put your hands together for my excellent panelists. Thank you. And let's take a group picture, please, for you. Vivian, if you could please come up.
Thank you very much, distinguished panelists. Okay, sorry about that. Okay, are we having a group photograph, please? Thank you. I would also like to invite the country director, result for development, Dr. Hope Wedger, to step forward, and the GM Legal Services NHIA, Barrister Blessing Nyenge, will have a group photograph, please. Dr. Chike Mwangu, the CEO of NOI Polls, please. Please kindly come to the podium for this moment of a group photograph. Thank you. And they'll be joined by the MD of Nigeria Health Watch, Mrs. Vivian Ihekwazu, please. Please kindly step forward to the podium. Let's have a group photograph. Ma'am, please. Yes, please. Thank you. Group photograph, sir. Yes, sir. Yes. Yes, ma'am. We have one more person, please. The CEO of NOI Polls. Has he left? Okay. You can go ahead. I think he's not in the room right now. Yes, please. All right. Thank you very much. We'll receive a presentation right away. Yes, sir. We'll invite the country director, R4D, Dr. Hope Wedger. Sir, you're welcome, sir.
Yeah, thanks. So, good afternoon, ladies and gentlemen. I know it's already a very busy day, so your time has been well taken, but I will just crave your indulgence to just give me about 10 minutes or thereabout. Let us review a topic that is quite germane as we want to work in Nigeria towards universal health coverage. When I raise my hand, I hope you see the slide, you change the slide. Yes. So what do we really mean by drive towards universal health coverage? If you ask every top management of NHIA, Federal Ministry of Health, even the private sector, health sector, they all say they are working towards universal health coverage. For the purpose of this presentation, I want us to be on the same page as it concerns the drive towards universal health coverage. For me, the drive towards universal coverage encompasses the following. One, the development, adoption, and guaranteeing of the benefit package, so that what we have is not benefit package in theory, which is not guaranteed at the facility level, but it's always happening when the patient visits the facilities, and then sustained progress towards national health outcomes. The second key thing is that the drive towards universal health coverage should involve utilization of the revenue levers and the expenditure levers that are available in order to be able to create a proper financial balance in terms of funding of health services, and more importantly, in achieving national health outcomes. And like had already been mentioned before, in achieving this financial balance, we don't want to start hearing of such negativities like out of drug syndrome, stockouts, deterioration in quality, etc. What do we know about health financing reforms and the drive towards universal health coverage? The body of evidence that has been accumulated, particularly in the low to middle income countries, actually indicates that there are three core principles that guide this process of health financing reforms as we work towards universal health coverage. One of them is the move towards predominant reliance on public funding. And that is why earlier, when I was hearing of private funding, private funding can never guarantee the drive towards universal health coverage. The truth is this: more than 60 to 70% of Nigerians are living below poverty line. How can those people pay towards universal health coverage provisioning? Secondly, there is need to reduce fragmentation in the pooling of funds. When NHIA started many years ago, there was only one single fund. Now we are working towards 37 funds. That is a lot of fragmentation, because each of those funds has its own administrative costs, which has to be addressed. Sorry. And then the last is the move towards strategic health purchasing. Of course, we have been purchasing health, but as we go along this presentation, we'll begin to see the difference between a passive health purchasing and strategic health purchasing. So what does the drive towards universal health coverage involve? Like I stated here, the drive would involve equitable raising and allocation of public financial resources. So if we look at what NHIA is supposed to be doing, NHIA is not supposed to really be the one accumulating and raising these funds. These funds have to be raised by the government. And when it is raised, it is transferred to the agency or agencies that would be procuring health. And when these funds get to the agencies, they are properly managed equitably and efficiently in order to be able to ensure that everyone within the country have access to the type of quality health services that they deserve. In order to be able, next slide please. In order to be able to achieve sustainability in this drive towards universal health coverage, you will see again that if there is equitable raising of these public funds and it is channeled to the spenders, and the spenders, in this case, the health agencies, particularly NHIA and the state health insurance scheme, now involve themselves with strategic health purchasing, which is well covered under the pink area of the slide. And you will see there that for strategic purchasing to properly take place, we need to manage the benefit package properly. We need to handle provider credentialing, provider payment, drug price negotiation, and market shaping. NHIA currently is beginning to do that. But more importantly, we also need to do data analysis and monitoring, cost sharing policies, and also gatekeeping. The whole aim being to ensure provision of quality services nationwide. Next slide, please. So what has been Nigeria's experience in terms of access to essential health services? If you look at this particular slide, you see that Nigeria, in terms of access to essential quality health services, is currently ranked 40 out of 100. But there are smaller countries there, countries that are quite smaller than Nigeria, like Malawi, Ghana, etc., that have done much better. This actually reflects the fact that we are not doing adequate strategic purchasing. So what is strategic health purchasing? Strategic health purchasing is a deliberate decision where those in charge of the fund decide what to procure. And in deciding what to procure, they look at the envisaged health outcomes. They decide which level of providers are supposed to handle the provision of these services. Or in other words, which service providers are they going to provide this service for? And then lastly, they ask themselves, how do we pay these providers such that there will be an alignment between funding and incentives compared to the various services that had been promised. So next slide, please. So strategic health purchasing actually has about 4 dimensions to it. A key part of that dimension is the governance of purchasing. So for countries who take strategic purchasing very seriously, they look at establishing very clear goals. What are we trying to achieve in the country? Why are you bothering about procuring so much about treatment for cancer when the basic things that are killing Nigerians, killing children like malaria has not been procured? So they look at arrangements, they look at institutional arrangement to be able to bring this about. And that's why I was appealing to the 2 core agencies that manage the supply and demand side to sit together to be able to provide the arrangement to strategically procure health on behalf of Nigerians. And then they want to leverage on information and build the capacity. One of the streams of our current project would help to build the capacity of Nigerian health procuring institutions to be able to build their capacity on how to properly procure healthcare efficiently and equitably on behalf of Nigerian population. And lastly, how to engage stakeholders. I was quite happy that for NHIS, they talked about the goods and services to purchase, providers to purchase from, and they actually need a lot of improvement in this area. It doesn't really make sense to me to go to a specialist center like NHIA, for example, because you want to procure health services. Next slide, please. So what are the conditions for strategic health purchasing? Again, people may come to tell you here that so much can be done from the private sector. I tell you that is not true. Government has the legal instrument to extract funding. The level of taxation in Nigeria, I must tell you, is very low. But that does not mean that we should not reflect the reality on ground. And one of the reality on ground is that the health budget is still the cornerstone for financing UAC. There's nowhere in the world where, apart from the major economies like United States, which is yet to attain universal health coverage anyway, Switzerland, which is yet to attain, where the drive towards universal health coverage is not driven by public funding. Then secondly, we must always resist fragmentation. Unfortunately, the move now is towards fragmentation. But my hope is that when it is possible for us to harmonize the benefit package, we might succeed in reducing the level of fragmentation in the system. And of course, Nigeria needs to learn from their neighbors. Ghana, Rwanda, and multiple countries have used strategic purchasing to procure health that has driven them positively towards universal health coverage than what Nigeria has done. So we now need to begin to discuss with them and say, how was that done? Next slide, please. Again, why does it have to be government budget? You will notice that for most African nations, they rely a lot on public funding. Most of those out-of-pocket contributions can actually be mobilized by government itself to drive this pool. Next slide, please. So, what are the ways to leverage this public finance in order to work towards universal health coverage? One of them is we need to understand the flexibility and constraints in the current public financial management. If you look at the current public budget, the federal government is spending a lot of money on health, driven through the supply side, whereas that money can be routed through the demand side. When you give, for example, the teaching hospital, I'm not saying they are not important. When you give, for example, 200 billion for tertiary health services without making them accountable, the returns and the outcomes will be very poor. And then lastly, we need to strengthen the dialogue between Ministry of Health and Finance to align objectives. When I listened to the DG this morning, I knew he still needed a lot of dialogue with the Ministry of Health, because both of them need to understand why these things need to work. And here, next slide, please. I don't need to look at this one again. Next slide. Again, here, we want to look at health insurance coverage. In the case of Nigeria, we started 2005, so it has been up to 16 years, or going to more than 16 years now. But if you look at the population coverage available internationally, you can see what it looks like. I'm not saying that this figure is exactly correct, but I'm trying to say if Nigerians have actually worked along one dimension of universal health coverage, which is health service coverage, at least for primary level alone, would have achieved far more. But we've taken a lot of procurement due to the very expanded nature of the benefit package. Next slide, please. Please, next slide. So, why is this important? This is important because many times when we are discussing basic healthcare provision fund budget, you see, what are the consequences of fragmented financing at facility level? In Nigeria currently, basic healthcare provision fund will come with its own, out-of-pocket payment will come with its own, local government funds, health insurance fund. When all these funds get to the facilities treat them separately. They will say, I will not use this for this, I will not use this for this. Between that argument, a lot of inefficiencies enters into the system and nobody is accountable for how those money is used. But in a more refined system, you will find out that all this money can be pooled actually and given once to the facility and to enable the facility to be able to effectively use them and for these funds to be well tracked. Next slide, please. So, in a nutshell, let me just say what I was trying to bring out is that in these last several years, Nigeria has been focused more on procuring health. How they procure health has not been targeted towards achieving results. Most countries will ask themselves, what are we trying to purchase? Why should we purchase this? It is very important. In a country like Mexico, what they did was to tell themselves that the most important service they first have to procure is primary health care. After procuring primary health care, then they begin to ask themselves, what next in terms of secondary care should they procure? When the budget man was there today, one question I wanted to ask, though we didn't have the privilege to ask, was, when the government decided that health insurance is going to be mandatory, when he decided that the vulnerable group fund was going to be created, did he really determine how much fund that was necessary to do that? There was no evidence to that. And that has always been the problem in our own country. Most other countries, they don't start by declaring the law when they've not first done what? Determining how much, what do they want to cover and how much. They strategically sit down and say, what do we want to procure? What will it require us to procure it? And how do we get this funding for this? Those are logical arrangements. Anytime it is not done in a strategic nature, we always come back to the issues. And that is why, for me, the government needs to do more in order to work towards universal health coverage. Next slide, maybe it should be the last now. So what are the practical steps to defragment financing for strategic purchasing? We need to integrate funding streams at the provider level. This one, like I said, one coming from NHIA, one coming from this, one coming from that. It will create a lot of problems. And then we need to harmonize service packages. And this has been done in other countries. Currently now, we are working towards this later achievement. And we hope that by the time we sit down with all the key parties, they will be able to do that. So let me just stop here. If there's any questions, I will take it. But the key lessons here is that it is one thing for you to be giving money. It is one thing for you to ask for more money. But it's also important for you to say, how do I deliver more health for the money you have been given. And as long as those providing the money don't see the value of what you are provided with the money they've given, they will find it extremely difficult to improve on that. Thanks.
Thank you. We move on quickly to our final panel session for this health financing policy dialogue. And this is on exploring innovative health financing mechanisms for the vulnerable group. I apologize. Exploring innovative health financing, mechanisms for the vulnerable group, which will be moderated by Dr. Gafar Alawode, Managing Partner, DGI Consult. Please welcome Dr. Gafar.
Good afternoon, all. I think the first thing is to promise you that we are going to be very brief because the sugar level is very low. I know that. So this afternoon we'll be discussing something very, very critical, which is part of why we are here to look at what are the innovative mechanisms for financing health. To do justice to that, have a very, very able panelists that will be part of this. We have Professor Olumide, who is provide technical assistance to the DG of the Budget Office. So Professor Olumide, please come and have your seat, please. And then we have Felix, very, very veteran in health financing in Nigeria. So Felix will be associate professor, apologies. You know, when you have a professor by your side, everything is professorial. So we have Felix Obius, Associate Program Director at Resort for Development. And joining us virtually is Dr. Olumide Okunwola, who is a Senior Health Specialist at World Bank. I want to be sure Olumide has joined virtually. So we'd like to start this discussion by congratulating all of us for the progress towards universal coverage. I think the challenge is still there, but the fact that we have an enabling legal framework that makes provisions for mandatory participation and provision for covering the poor and the vulnerable, I think is a giant stride. So the next step is to look at how do we translate that to action that will ensure that we cover the vulnerable that is put at more than 100 million population in the country. So I would like to start with Professor Olumide. Professor, from the public financial management perspective, what are those practical steps that you think we need to take to actualize most of these innovative financing options? We have seen in recent time a lot of effort made towards ensuring that sugar sweetened beverage tax is earmarked for health, but it has not materialized yet. And we are talking about a number of other innovative financing options. So from the public financial management perspective, what are those specific things that we should do in the health sector to realize those, Prof?
Thank you, sir. I want to thank the HealthWatch Foundation for this opportunity to participate in this important discussion. And coming to the question, we've been talking of innovative financing mechanism. And I said, why are we trying to innovate when we have not even explored the traditional sources that we have? I think the starting point will be more effective engagement between the Ministry of Health and the Ministry of Finance, Budget, and National Planning. Going through the NHIA Act, I could see that there wasn't much of that engagement. Because I see there health levy. And I say health levy.
Health insurance levy.
Health insurance levy. Levy on what? Because if there had been engagement, that would have been very, very clear. You know, levy, like the sugar levy, for instance, is direct. You know, what is the percentage on which particular good or which particular sector, or maybe profit on a particular sector, and so on. So it's important that now we have the Act. It's important that the leadership of the Ministry of Health, we engage the leadership of the Ministry of Finance, Budget, and National Planning on how to give effect to the proposal of the Budget Office. Let me remind us that the DG Budget Office mentioned that rather than fragmenting, you know, earmarked taxes, we could increase the rate, you know, for the Basic Healthcare Provision Fund to say 2% or more. Of course, in the Act, it says minimum of 2%. But then, if it is minimum of 2%, then, you know, when it is 2%, the office meets the law, the demands of the law. So, and then to also increase the base. And, you know, the Finance Act 2023 will be in the works. So as soon as a new government comes into place and you have, you know, a new leadership in the Ministry of Health, it's good to take this up so that as the Finance Act 2023 is being developed, this can be incorporated. And, you know, since it is part of the provision in the NHIA Act for health insurance levy, the Finance Act 2023 can amend that section of the NHIA Act to give specificity. Because you may find out that the 2% to the Basic Healthcare Provision Fund of the Federation account may not be up to what you want, because I know health sector always wants more. So now, in addition to that, you know, specific levy can now be introduced through the Finance Act 2023.
Okay, thank you very much, Prof. I think this is very, very helpful, and we're having some specific next steps that you are recommending for us. So let me go to Felix. So Felix, there is huge inequity in health access in Nigeria, and we have the opinion that if we're able to get additional funding through innovative financing, we are going to bridge those gaps. So from experience as financing expert and looking at what is happening in other parts of the globe, to what extent does this innovative financing help us to bridge this gap?
All right, thanks, Dr. Gafar and everyone here. So I think, first of all, we should try to unpack the inequalities that poor and vulnerable people face. So the inequality, maybe from the perspective of financial access.
Absolutely.
And then, so for financial access, so several countries, obviously, like you know, have used different innovative mechanisms in terms of financing. For instance, in Ghana, our neighbor, they have used VAT for a long time to finance their health insurance, and several other countries. And outside even Nigeria, those who are within the same range in terms of income level, they've taxed alcohol, they've taxed tobacco, and in some countries they've been able to finance through these mechanisms. So I think for Nigeria, we, like he did say, I know, for instance, the sugar tax, the alcohol tax, and all of that, even if it comes, the problem of displacement can happen. So I do agree with Dr. Ben on the point of if we can advocate for like minimum of 2% so that we have a larger base. But more importantly, I think we should think of how do we target the poor and vulnerable. So in the past, we used fee exemptions. If you remember the era of governors that we are doing free maternal and child health care. Now, that was a very good strategy, but the only problem was that most governments didn't think through the financing. So you kind of announce free services or exemption, remove the exemption fees, kind of remove the fees, and those who were supposed to like benefit from that didn't quite benefit. There was a study that the Health Policy Research Group did in Enugu State for free maternal child care services, and it was even found that people who benefited, it was a kind of who benefits from this service, and it was found out that it was even more of people...
Benefit incidence analysis.
Yeah, benefit incidence analysis. We found out that it was more of people who were more educated, whose wealth quintile was maybe a lot higher, because they had the fund, for instance, to transport themselves, and they also know about the
awareness was there.
So information was a barrier, and the first panel we had, the person representing the women who had hearing disabilities confirmed that because they don't have the right information. So the poor and vulnerable need to properly map them, know what are the real barriers they are facing, and then the funding that we get can be used to like address those inequalities in terms of financial access and also even accessing the services. Because accessing services, if you have everything ready at the primary healthcare level, information need to go to them. And I like the fact that the issue of Jikwe mentioned that. So at the community level, where this majority of poor and vulnerable people are, we need to make sure that we provide them the right information about the existence of programs that target them, and also make sure that the funding mechanism we have should be able to bridge the financial gap that prevents them from accessing services.
Okay, thank you very much, Felix. Before I leave you, I want a rider to that. So you are looking at the issue of accurate targeting of the beneficiaries.
Absolutely.
So in that case, will you recommend the use of this as social register? Is it very, very useful?
I think our social register has great potential. Now, I think it was earlier in the week, maybe Monday, the president sent a request to the National Assembly to approve the borrowing of $800 million of loan from the World Bank to provide cushioning for the poor and vulnerable within our society. So in a sense, we already have the framework for the social safety net. I think we need to find a way to layer in our health outcomes into that. So for instance, rather than just give women or families 5,000 for their upkeep, is there a way we can use the same mechanism to provide access to essential health services to them? So the social register is a great potential for us. I know there are issues about who is included and all, but we did some work with Niger State, in the past, where we worked with the state contributory health scheme to see how they can clean up the register, and of course in collaboration with the community leaders and traditional leaders, so that you know that those who are included in the register are actually people who meet the criteria for being poor and vulnerable.
Okay, thank you very much, Felix. I can see Olumide is there. Olumide, good morning, good afternoon, depending on which part of the globe you are. Can you speak so that we are sure that the technology is in your favor?
Okay, I hope you can hear me. Yes, I am at the Lagos airport. I got stuck at the airport. So please confirm that you can hear me loud and clear.
We can hear you loud, clear. I'm not very sure, but we can hear you. Okay. So I think there is echo somewhere. Okay. So, Olumide, thank you very much for joining us this afternoon. So, these conversations around innovative financing towards expand health insurance coverage to the poor and the vulnerable. So, I want to hear from your perspective. There are a number of options being put on the table for as innovative financing mechanism. So, I want to hear from your perspective. World Bank has supported a lot of our innovative financing initiatives. So, the question here is issue of viability and sustainability of options. What are your thoughts in terms of which options should we pursue that is credible enough, can give us more resources, but at the same time is sustainable? Olumide.
Thank you so much, Dr. Gafar. Just to mention that you have a solid set of panelists who's pretty much done justice to most of the things I want to say. So that's why I would probably want to start by laying some foundational comments. And I'm just going to make 4 very quick points. The first point I want to make is that it's not news if I say Nigeria's public spend on health is so low that it's almost unbelievable. But that situation is even going to worsen with the current fiscal constraints that we have, which means that for a country that is spending so low, the way the economy is going, it means that if we don't prioritize health, the level of spend would even go lower than the current 0.5% of GDP. So what do we need to do? The first thing is, with the way the macro situation is, government needs to increase public spending across board. But within that increase in public spending, it needs to ensure that health is prioritized within that level of spend. In fact, for countries that have achieved universal health coverage, it is the period of great financial crisis that they even increase the financing for health. Nigeria doesn't have a choice in this regard. Yes, there's no money, but sadly, it must increase prioritization for health and actually increase spend. Otherwise, the per capita spend for health will go drastically down, and that will be very dangerous. It's important to just make that first point. The second I would like to mention, which Dr. Hope made very clearly. Can I continue?
Please do.
Dr. Hope showed a slide. That slide was from a paper by Cherry Kashim and a few others, which showed that, look, for countries that have been able to achieve universal health coverage on the African continent, Gabon, Ghana, Rwanda, if you look at their data, a lot of the health expenditure went through the national health insurance schemes of those countries. So here in Nigeria, you have established, you have a national health insurance. Of health expenditures going through those health insurance agencies is below 1%. In the countries that have achieved universal health coverage, the minimum is 10%. So in other words, you have bought a car, you have bought a Rolls Royce, you have borrowed money to buy a Rolls Royce, but you parked it in the garage, you are not driving it. So there's no point. So first is, before we begin to ask for additional money, these health insurance entities, do you want to use them or not? Because right now, the data is showing that you are not using them. That's the slide Dr. Hope was showing. It's very important to this discussion. Anyway, that's my second point. The third point now is the reason why we are saying we want to use these health insurance entities is because there are some reforms embedded in them. And that brings us to the point of what you are asking me, Dr. Gafar. Because when you use health insurance entities, then I need to know who the beneficiaries are. I need to know the package that I am giving to them. And I need to know how the providers who are delivering services will be paid. That is the difference between using this health insurance mechanism that we spend only 0.6% of our health residues through, compared to the Ministry of Health model, where we pass all of the monies through, but we don't know who they are serving. And then the first point I made was you need to prioritize health, even in a situation of great fiscal constraints. So you don't have money to take care of everybody. What do you do? Whilst answering that question, you must also answer another one. You cannot create a parallel system where, for the poor and vulnerable, you give them a tiny package. And then for those who are able to afford it, they have a comprehensive package. My suggestion will be, and Felix has alluded to that point, let's use the National Social Register, which is owned by state governments, to begin this conversation. And that's what Professor Lumide said. Let's even do the math. Has anybody done the math? Right now, there are almost 12 million households on that registry. If we give them, one household is 6 Nigerians. 12 million households will be more than 50 to something million individual Nigerians. If you give them a package of, say, on the average 40,000 naira, which is a comprehensive package, not a basic package, how much will that be? And then you can begin to use that to titrate to say, this is really how much we need, and this is the number of people I can cover. And my last point will then be, so where will this money come from? Because I just did the math and I'm getting about 600 billion, which is affordable for Nigeria. In fact, if you give the health system 600 billion today, we will be scampering around to find where the money will come from. And I close by giving you where that 600 billion can come from. Number one is the point Professor Ayodele has made. Get money from the net federation account, not the consolidated revenue of the federal government. The net federation account is the big pot of money that everybody shares, federal, state, local government. And that way, you are able to also hold states and local governments accountable. And to get that, you need the consensus of the Nigerian Governors Forum. If the governors agree that you should take the money from the net federation account, in fact, you will get almost 100 billion from that, plus the BATPF. The BATPF gives us about 50 to, on the average, about 50 billion per annum. If you get an additional 1% or 2% from the federation account, that would be pushing you almost to 150 billion. The second place where you can get money from, which is the easiest, in fact, I don't believe that Nigeria cannot implement that, is to increase the current excise duty on sugar-sweetened beverages, alcohol, and tobacco. Don't let's even increase it to the level of what WHO has recommended, which is 20%. Right now, Nigeria excise duties on these health-damaging products is the lowest in the sub-region. Let's even bring it to the average of what Togo, Benin, Ghana, what they charge. That will give you 250 billion minimum. If you raise it to the level of what WHO has recommended, you will get almost 500 billion per annum.
Oh, okay, Olumide, let me, I think that's very, very helpful.
Reduce telecom taxes.
I'll come back to you.
Anyway,
I'll come back to you. You've made very, very important points.
Together, you are able to fund universal health coverage for the poor and vulnerable in Nigeria. Thank you.
Okay, thank you very much, Olumide. That's highly appreciated. Okay, great. So let me go to Professor Olumide. I think there are two sides of the coins when we are talking about financing. On one side, we are looking at more money, less more money come to the health sector. The other side is that efficient use of that resources. And that is usually one of contention between the health sector and your office, the budget office, when it comes to asking for more money, because you always give us the impression the resources that we have, there is no efficient utilization. From your own perspective, what would you like to advise? Let's assume we had made progress, we have been able to accumulate additional funds to go into the vulnerable group funds. What would you like to advise in terms of what to put in place to ensure efficiency? Prof.
Thank you, sir. But before I answer your question, I want to stress the point that mandatory health insurance puts a lot of responsibility on the government to provide the resources. Because when you say it is mandatory, it means that everybody will have to have it. It's not like a motor vehicle insurance, that it is only those that have motor vehicles that need to have vehicle insurance. But the act is saying that every Nigerian, everyone resident in Nigeria needs to have, insurance. And there are many people that will not have the ability. Students, unemployed youths, convicts, awaiting trial men, under 5, as we have in the Act. So it means that since it is mandatory, then it is by law, it's compulsory, it's important. So there has to be funding. Meaning that subnational governments must be interested in agreeing to proposals for them to contribute more. Very important. Because when we talk of changes in revenue allocation formula, it's very political, there will be resistance, and so on. So it's mandatory, then more money has to be provided. I may not agree with Dr. Okunola as to whether, investment in the health sector is very low, because the question is nobody knows the figure. Local governments, state governments, federal government, how much are we actually spending on health? Which brings the, part of evidence, studies, research into this issue of implementation of the Act. How much, evidence are we generating to be able to take decisions? So there is need for, a lot of studies to be able to bring up the numbers, to be able to bring up the information that is required. I agree that there is need to prioritize the health sector in resource allocation. And it is in that light that the Director General Budget Office of the Federation was proposing that, we can increase the percentage of the allocation to the Basic Healthcare Provision Fund, and then the base, and, maybe the sugar tax or, can be increased if stakeholders agree, amending the NHIA Act, that aspect that deals with,
health insurance levy.
Health insurance levy, can be tied to that. Now, if that is done, the sugar tax has to be earmarked for health insurance, But we cannot overemphasize the need to ensure that we know who and who, is vulnerable, who and who is indigent in each of these communities. So the register we have now can only be the starting point. We need to, have a very robust database of who in the FCT, we qualify. And that compartmentalization is important between those that have the ability to pay, premium packages, ordinary packages, and so on, But the vulnerable group must be able to have access to at least basic services. Coming to your question, talking about, more productive use of allocation to health, I want to say that is actually where the problem is. More efficient allocation of resources in the health sector will help the health sector to have more money. Now, when we look at the budget of states, how much of these resources are allocated to primary health care services? When we look at the budget of the Federal Ministry of Health, how much of it goes towards, primary health care, prevention of diseases? How much of our budget goes into water, sanitation, hygiene? Because when you prevent diseases, then you won't need to spend so much under this health insurance. Because health insurance is about pooling the resources from so many, contributors, and then not many of these contributors, needing the resources. But if you have the resources and, what you have gathered is not enough to meet, the demand, then there may be, distrust, in the insurance system. Thank you.
Okay, thank you very much, Prof. Before I go to the audience, Felix, to be able to make sure that we are able to harness these innovative health, financing potentials, we need a lot of stakeholders to come together. In your own opinion, how can we have a better stakeholders engagement to move this agenda forward?
Yeah, thanks a lot.
A couple of minutes, because,
So it just crossed my mind. I said most times when we are discussing health, we hardly have people from the Ministry of Humanitarian Affairs and Social Safety and all. So, and it is really critical because the poor and vulnerable population groups are the ones who should be captured under the social safety net. So I think all our conversation, we should actually start with them. So they are a critical stakeholder. And of course, the other bit is that I also realize that we often don't I'm not sure there's anybody from Ministry of Women Affairs here. Possibly not. So we have the Ministry of the Commission on, we have a National Commission on Persons with Disability. And this covers a large population of Nigerians who are poor and vulnerable. So I think we should start expanding in terms of our stakeholder mapping. Maybe not, of course, finance are people we should always be working closely with. But beyond them, I think there are other key stakeholders, even the private sector, for instance. So the private sector, one thing I want to add about the private sector. So we've started the Adopt a PAC strategy, but I don't think the demand side, the financial risk protection component is included. So maybe that may also be one conversation we can start having with the organized private sector. So if you're adopting a primary healthcare center, you're helping them to improve their facilities and all. I think we should also think of how many people will be receiving services from there. So whether it is through BACPF, so that the private sector can cover the financial requirement for providing those services in terms of like maybe either through BACPF or state social health insurance scheme, so that their premium for them can actually be paid, and especially so that in that MOU or arrangement, the benefit package to be provided at the health facility should be included in the provision they are making in terms of adopting a PAC to make it functional. Okay, great. Thank you very much. That's very, very helpful. So I'll go to the audience now. I will take a couple of our questions or contributions. Do we have Dr. Hope, Rachel? Oh, good. Only two. Okay. So let's start with Dr. Hope, then Rachel, and look at other. Yes. Can somebody help with this? Okay, thank you.
Thanks a lot. I just wanted to add, because Prof is around, and I'm told he's the advisor to whatever. So, Prof.
To the DG budget
yeah,
office.
DG budget, thanks. See, the truth is that the federal government has always viewed health as a social service. And once you view health as a social service, you will never see the investment case for health. When I was in GTZ, when health insurance was to be introduced, then the German government said they were interested in this case because health sector is one of the largest employer of labor, and the GDP contributions of health is major and significant in any part of the world. So when the government wants to look at the issue of health, it shouldn't just look at it that I'm taking care of what will not bring returns. The UN Commission on Macroeconomics and Health actually established that 50% of the progress made by developed nations can be traced to their development to health. So my advice is this: that subsidy removal, when I was a youth corper, 1987, I participated on that debate. And the consensus then, by 1987, when that debate took place, was that the subsidy issue was corrupt, inefficient, and it was not targeted equitably towards those who really should benefit from it. So it was those who have that are still benefiting, and it took almost 30-something years. It's still the same. So my appeal is this: this subsidy on petroleum that is going to be removed, please, sir, the major way for Nigerians to benefit is to drive it through the demand-side financing for healthcare. And that is how government can make the most benefit on it. And I want to appeal to you to tell them they should stop seeing healthcare as a cost center. It is one of the greatest ways by which Nigeria can be transformed. Because without a good healthcare, apart from all the jackpot you are seeing, there will be deterioration in terms of the economic standard, and your hope now, like what they stated, if you look at the depth of the country, and if you look at the economic situation, you definitely don't want to make it worse. So let me stop here. Thanks.
Okay, thank you very much, Dr. Hope. Rachel.
Thank you very much to all the speakers. I am just thinking aloud, what figure do we really need to put behind the vulnerable population? How much do the government actually need to cater for the vulnerable population? I think if there's a figure behind it, we'll know what we are targeting. Thank you.
Okay, thank you very much. Any other? Bola.
All right. Good afternoon, everyone. My name is Bolanle Olushola Faleye from APT Associates, implementing the USAID Local Health System Sustainability Program. My comment is on two things we have said here today: making an investment case for health and stakeholder engagement. And this success I'm sharing today started from in September 2022, when we supported the Nasarawa State team, because the executive governor of Nasarawa State was going to Chatham House talk about universal health coverage. And we articulated 5 major asks, which we fielded in a question and answer session like this. And we said, we want you to do this, this, and this for your people. And he committed to them. And today, I can say that 2 of those major asks have been accomplished. In December, we followed up stakeholder engagement, that question that Gafar asked Felix. In December, we followed up with that discussion in Chatham House with a meeting in Abuja here, where we brought local government chairmen to Abuja for a meeting. We did not stop there. We invited the Algon chairman, invited the labor, invited all kinds of religious leaders and traditional leaders. And we said those things that the governor spoke about. He mentioned that the money, part of the money will come from the local government areas. See, somebody said it earlier today, the federal government alone cannot pay for all the health needs of this country. It has to come, and that was why the DG budgeting talked about getting money concurrently from all the different levels of government. And the governor said, I need my local government areas. He said the word, and we just followed up with it. And today, the local government areas in Nasarawa State have paid equity fund. This is something some states' governments are still struggling with. So it takes advocacy. It takes making an investment case for health. And Olumide, who is speaking online to us today, was one of the major technical specialists we called to talk to our local government chairman. And we got a few other people. Gafar was also there. And they listened. And the way they listened, I knew they were hearing some of these facts for the first time. These are local government chairmen. And as I speak today, just last week, they've paid equity fund to the Nasarawa State Health Insurance Agency. So I think it's worth celebrating and it's worth learning from on what advocacy and packaging the investment case for health can achieve. They did not stop there. They started deducting from the payroll of local government employees so they can also have health cover. That was why we needed the labor to be there and to agree to that plan. So 5 asked, 2 already achieved, and the 3rd one in line. I'm sure there will be also a fora to share some of the successes that we are recording from LHSS.
Okay, thank you very much for sharing that success story from LHSS. So I guess it was only one question we had, the others were a contribution. Any other one? Okay, young lady at the back. Oh, we have, okay, you and only 2 of you, and then we round off the question and answer section. The moderator, the anchor want to deny you that opportunity. Okay, let's ask the question quickly so that we'll move on. Okay, so only 2 more, yeah, exactly. Thanks.
So thank you all for the great lecture and the Dr. Kola online. My own question is on this NHIA Act that has actually expunged the telecoms deduction. I'm just asking, is it possible, especially for the legal people, can we put it back? I know it's like they say they're still trying to finalize and do that, but is it possible to now put it back? Because from even the DG said, and maybe he's unaware, he was already budgeted that maybe 100 billion could come out of it. But from what we are learning, it has been expunged from the Act. So is it possible to put it back? My name is Dr. Idowu from AXA Mansard. Thank you.
Okay, thank you very much. And the last one from the young lady at the back there. Thank you.
Okay, good afternoon, everyone. And standing on existing protocols, I'd like to inquire, what modalities have we put in place to checkmate these expenses? Because when we were speaking, and I can also understand from Dr. Hope's point of view, I am from budget, and we've been doing some form of tracking. Now, lately, we started tracking PHCs in some specific states. And the engagements we've had with some of these executive secretaries and all of that is making people realize that things have to be put in place. Just 5 states alone, and we have people on their toes already. So what modalities do we have to put? In as much as we're talking about subsidy removal and all of this, we're channeling this to the health system. We are still going to have a repeat of what has happened. 1987 is a very long time. That should be about 35, 36 years. And we're still having a cycle of this thing. When the doctor from AXA Mansard was talking, she's talking about brain drain. People are leaving. Yes, for those of us who are here, what are we doing to ensure that anybody who walks into the system can have access to healthcare services? I'll share a personal experience. I had my internship here in Abuja some years back. And I remember working for a private facility where I would write medications and the MD will call me and tell me to step down the drug. Why? Because it's health insurance. I walked away. I was in the HMO. I spent 1 week and I put in my resignation letter. Why? I would write a medication and somebody tells me that because the patient is paying through health insurance, they should not be giving that drug. So I had a case. And then I sat in front of a board of directors. As a young doctor then, I said, I am not the patient. I am not the patient's relative. But when a medical personnel makes a judgment, it is based on the clinical presentation. So why would a patient be required a particular line of antibiotic and I'm giving the person what I know I would not give to my own relative? And they said it was because, there are some policies before the money will come down. I said, see, it is important that we take note that once I pen down something, I am liable for that health or the life of that patient. If we lose that patient, nobody knows what is the negligent part on the doctor. But at the same time, we all give account somewhere. So what modalities have we put in place to checkmate these things? I'm Dr. Davison from Budget. Thank you.
Okay, thank you very much, Doc. That's highly appreciated. So, Phyllis, let me start from your hand. There's a question from Rachel in terms of vulnerable. What do I have a figure in mind? How do we want to reach them? How do we compute in it? Do you want to answer that?
I kind of build on what he said before, evidence. So I think we need to, as a country, properly map who is vulnerable, define who is vulnerable, and then capture them within a system like the social, maybe the social register can be a place to start. But I think maybe this will require both the National Bureau of Statistics, even the National Population Commission. We are supposed to do a census. Maybe the census can be an opportunity for us as a country to really know who is poor and vulnerable in general. But I think we need the evidence. I completely agree, because it's when we know the evidence or the number of people and then the benefit package that is costed, we can now maybe do the proper calculation. But for now, I think we can do some bit of modeling to get the figures we need. But to get exact figures, we essentially need to have a robust social register that captures everyone that is poor and vulnerable.
Okay, thank you very much. In addition to that, just to mention that the National Health Insurance Authority put in place a committee on innovative financing, and part of their responsibility is to compute the figures in terms of how many people are we talking about, what is the unit price, how much is it going to cost us, are we talking of everyone at the same time, what is the, are we going to fix it? I think there is evidence being generated to support that as well. Professor, there's a question around the removal of telecom tax as part of financing the vulnerable group fund. So the question is, can we put it back? But let me ask, is it possible for because you've mentioned an opportunity around Finance Act 2023, can we hide under that to bring this telecom tax, or are there other options?
Well, everything boils down to engagement between the Ministry of Health and the Federal Ministry of Finance, Budget, and National Planning. And the starting point will be the last point that was made about evidence. Because budget engagement has to have evidence. How much money do you need, for this category of beneficiaries? And these are the packages that you have for them. And this is the distribution across the 6 geopolitical zones. So when you have this evidence from the Ministry of Health and in the engagement with the Ministry of Finance, it makes it easy for decisions to be made and for resources to be allocated, in a way that the health sector is going to have more resources. But then I must make the point that it is not true that the Ministry of Finance, Budget, and National Planning sees health as a social service. I remember very well, Health Watch had an event, Political Economy of Health, and we clearly explained the link between health and economic performance. A healthy person will be a productive person. A healthy person will earn income. A person who earns income will pay taxes. So there's a link between revenue generation and a healthy population. So the ministry is clear on the benefits to health spending. But the ministry is concerned with the utilization of resources provided to the health sector. So, because of the fact that the ministry, accords a lot of, priority to health, in that event, we showed the trend in, allocation to the health sector by the Ministry of Finance, Budget, and National Plan, and it has been growing over time. So, the sector needs to demonstrate, effective utilization of these resources. Talking about the telecom tax, the Finance Act provides opportunity for, review of legislations. I think Finance Act 2021 already has, tax on the telecom sector. So I believe it was deleted from the NHIA Act because it was already in the Finance Act 2021. And you know that if you were in the news recently, there has been some discussions around whether people should ignore, the circular from the Ministry of Finance, Budget, and National Planning, But I believe, from next month, I believe that issues around that will be sorted out, So there's opportunity for that tax to be implemented. If MTN is paying such a tax in South Africa, why will MTN not pay it in Nigeria? But for me, the point will be to earmark it for health insurance in the Finance Act. Thank you.
So thank you very much. The last one I'll answer it around accountability checkmating. I think the good opportunity, the good opportunity here is that we have, it's been, accountability framework for basic care provision fund is being designed that look like resources being spent, where is money going, and what is the service that is being delivered as a result of that. It has been piloted. It's going to be finalized. Everybody will be part of it. I think some of those important questions you raised will be part of it. Dr. Jonathan, you wanted to say something? You've been itching to say something. Quickly, have a second, please.
Dr. Gafar.
Yeah. Olumide will take the final award from you. Somebody should give Jonathan the last contribution, please. Just a minute, Dr. Jonathan. Then last comment, 1 minute from Olumide, then we'll round off this section.
Thank you very much, Dr. Gafar. What I want to say is in connection with, when we're talking about this telecoms tax, it's as if we are taxing those companies. I want us to understand that it's like a levy, which Nigerians are making a contribution, not a tax on the companies. It's important we get that. Because I know that's where a lot of us have made that, because we'll be talking about the telecoms company going to kill it. It is a contribution Nigerians are making, and it is very, very progressive. Very, very progressive, because the quantity of calls I make every day will determine how much I contribute.
Absolutely.
So the only thing is a political way for government to say, let's take it because it's the people that are making this tax.
Oh.
The only thing is that maybe we are using the instrumentality of those telecom organizations to collect it. That's just what I want to.
Thank you for that clarification. That is highly appreciated. Please.
This presentation should have been made to the Ministry of Communications and Digital Technology for them to understand that,
absolutely,
it is not the providers that are paying.
The telecoms are just the channels for.
But they will also tell you that it affects demand, and it will affect their profit. I'm an economist. I know the channel. So, before the Health Insurance Act, brought up this telecom tax, the Fiscal Policy Reform Committee actually did a robust work on it and included it in the Finance Act 2021.
Okay, thank you very much. Olumide, 1 minute, please, because our time is fast spent. 1 minute, last comment from you.
Very much, Dr. Gafar. Just to add my comments to the one on telecom tax. If Nigeria raises its taxes on telecoms to only half of what, for example, MTN pays in South Africa, then you would generate the kind of funds that we're talking about. So again, the tax to GDP ratio in Nigeria is at 6%. It is the lowest in the sub-region. That's point one. Number two is that I'm showing now the number of individuals, households enrolled in the National Social Registry, developed by state governments in Nigeria. This was as of April last year. There are now that it's about 15 million households. Nigeria has one of the most advanced registries in the world, and it provides a basis to make progress quickly. The sad thing about the social registry is that it is the health sector, we in this room, that have not fully engaged with the social registry at the state level, where you have the state health insurance agencies not even agreeing that this is useful or complete. And the last point is that when you use an output-based budget like this, like Professor Adele said, how many people do you want to cover? Multiply it to what you think your benefit package is, and then you make a case. So here, I just quickly ran an Excel to say, look, a comprehensive package costs 440,000 per household. This is 600 billion if you want to cover everybody on the National Social Registry today. Nigeria can afford this. And we need to fine-tune and refine this kind of investment case, Dr. Gafar. And I think that Nigeria actually has the opportunity and the potential to be able to make this a reality. The accountability framework that is being developed, it cannot be developed by civil society alone or even by the entities. It needs to be developed in conjunction with the budget office, because it is the budget office that will make budget transfer based on the monies available. At least let us try and still work on that if we can. Because if the budget office does not agree to that accountability framework or is not aware, then it will be no work done. Thank you so much for this opportunity.
Okay, great. Thank you very much, Olumide. Our time is fast spent. At this point, I'll quickly summarize the important points we have discussed so far. I think part of what came out clearly is that effective engagement of the budget office is very, very crucial for us to understand, have a better understanding of the budgeting processes. He has told us a very big instrument that we can leverage, which is the Finance Act 2023. I think we can explore how health insurance levy and other mechanisms that we're actually pursuing could be delivered through this Finance Act 2023. That came out clearly. And it also came out clearly in terms of, instead of looking at different tax options, I think we should be targeting the consolidated revenue, because everything still comes together and enter that pool, consolidated revenue, and that come out clearly. In terms of reaching the targeted population, the instrument, the tool that we have is the social register, but we have to clean it up so that it is those people that we really need that are part of it. And there's a better, there's a clarity around when we say mandatory participation. What is important is the mandatory subsidization on the part of the government, because we are talking about everybody. We are talking about people that are not able to pay. Even when you say premium is 10 naira, they are not able to pay. So mandatory participation is very, very key. It also came out the issue of evidence generation. Let the whole process be supported by evidence in terms of planning, in terms of allocation, and to achieve allocative efficiency as well. Again, we have to do better in terms of our stakeholders' engagement, private sector, and other people that need to be part of the discussion. We have to look at platforms that bring everybody together to have a continued conversation. And again, we have to make a better case, better investment case. We saw change ourselves in the health sector. Even the basic care provision fund that we are implementing, we hardly talk about the employment generation component of it. Whereas the 10% of the basic provision fund is for human resource for health. And it is who are we employing? They are Nigerians. So we should be making that case that it improves employment opportunity, it reduces poverty, it increases economic growth. And then there is a discussion around accountability framework as well. And Olumide point around working with the budget office to ensure that we have a very, very broad workable accountability framework. So on this note, I would like to thank you very much for listening to the panel discussion. And I thank the panelists, Professor Olumide, Felix, and Dr. Olumide for the wonderful contribution. By the power conferred on me, I would like to disband this panel, and this is hereby disbanded. Thank you very much.
Thank you. Please, we invite Viviane Hekwazu, Kemisola Agboye for the group photograph. Yes, please. No way, I can't. Thank you. Thank you, Dr. Gafar Alawade, and esteemed panelists for this thought-provoking, engaging session on how to include the vulnerable groups so that everyone can have equitable access to health services and we achieve the universal health coverage, which is the ultimate goal. I have two more tasks and we'll call it a day. First of all, we have documented over 20 actionable call to action points and recommendations from the various panel sessions. So I would conclude with a few of them, but please be rest assured that these points will be put together in a communique and shared with the guests after this event. So from the first panel session, we have a recommendation that says that more opportunities should be created for sensitization, especially around the NHIA Act. People need to be more aware to increase awareness on the importance of the health insurance coverage, and local languages should be employed for the grassroots level to ensure everyone understands the message. And we can go on and on to emphasize and re-emphasize on inclusion. Include persons with disabilities in the planning and designing stage of the health insurance coverage policies. Make messaging accessible to vulnerable groups to ensure they feel included and valued. There was a certain punchline made by, during one of the first panel session, where the member from the informal sector mentioned, you cannot buy ingredients for yam porridge and midway you want to prepare vegetable soup. So at the design stage, everyone should be included. And then from the second panel session, remember I said there are a whole number of these call to action recommendation points, but I'll just read out a few because of time constraints. We have to clearly define roles for purchasing and ensure that there is a better distinction between them, between these roles, to avoid confusion and also to improve accountability. We need to strengthen the state-level implementation of the NHIA Act to ensure that all stakeholders are engaged and involved in the process. Improve accountability and transparency of funds to ensure that they are being used effectively and efficiently. And we should also ensure the effective implementation of the NHIA Act and engage all stakeholders to promote collaboration and involvement. On that note, we are finally coming to the end of today's event. I would just like you to applaud yourselves. You have been such wonderful, wonderful guests. Thank you very much for remaining very engaged and participating all through the sessions. And on this note, we bring this event to a close, but not after a group photograph. So please, I would request now that we all come to the podium for a group photograph, and that will be quickly followed by a group lunch by every one of us. Thank you. Group photographs. There's a barcode displayed on the screen. Kindly scan with your device. It's for post-evaluation of this event. Please scan the barcode and take the post-evaluation survey. Thank you. Please, His Excellency, sir, His Royal Highness. Please come forward to the podium for the group photograph. Dr. Gafar, Mr. Felix, Dr. Ogbe, Dr. Jonathan, Dr. Bolanle, Barrister Blessing, Nigeria Health Watch staff, please come forward. Market Women Association, the Taxi Drivers Association,